Hi, this is Jean Deschamps from Université de Montréal and SonoVault in SonoUni. This video will discuss the typical pulmonary ultrasound findings. This is part of a series of educational videos related to lung ultrasound. This video depends in part on the technique video regarding lung ultrasound. At the end of this video, you'll be able to recognize normal findings, recognize B-lines, recognize constellations, and recognize pleural effusions. Pleural lining assessment is one of the earlier things that is taught to ultrasound learners because it relates to pneumothoraces. Pleural sliding is a shimmering of the pleura that is timed with each patient's breath. It is sometimes compared to ants walking back and forth. When assessing for pleural sliding, the probe has to be positioned anteriorly on the chest in the area of least amount of dependence. Usually, one will use the curvilinear or phase array probe initially as it is versatile for other parts of the whole body ultrasound. Proper optimization requires decreasing the gain maximally to improve gray-white differentiation, decreasing the depth to improve axial resolution, and ensuring the focus is on the pleural line. If still unsure, create a difference in the image by asking the patient to stop breathing or creating an inspiratory hold on the ventilator. We are, of course, better at analyzing changes rather than fixed images. In some situations, it remains difficult to determine if there is pleural sliding on one of those probes. In these cases, changing to a linear probe may improve sensitivity. The same optimization tricks are applicable. Now, notice how this is easier to see with the linear probe. This is a comparison of sliding and absence of sliding from the same patient using the phase array probe. Notice how on the non-sliding clip there is no shimmering of the pleural lining. Remember to place the probe at the site of the least dependent lung. The presence of sliding may be visible in one site but not another, because the pneumothorax may just not extend that far. To give you an additional idea of how this looks, this is a comparison using the linear probe of both a sliding and not sliding lung. The next set of slides will be talking about Alines. Alines are horizontal lines parallel to the pleural lining that are seen at equal distance, usually a multiple of distance between the transducer and the pleural lining. These are normal features that are non-specific. Alines are reverberation artifacts from a bouncing ultrasound signal between a highly reflective surface and a transducer. Ultrasound processing determines the location of an object based on the time for a signal sent to be returned to the transducer, since sound wave speed is fixed in tissues. The returning signal is absorbed and processed, but some signal bounces off the transducer and returns to the tissue. As it takes twice or 3 times the amount of time for each bounce to return, the ultrasound assumes there is structure deeper. Because of this, it is at equidistant depth from the first or true image. It also leads to a less intense signal as each bounce loses energy. In some situations, it appears like there are additional smaller A-lines within the lung distal to the pleural lining. These are similar to A-lines and represent reverberation artifacts from other highly reflective structures, such as fascial lining or muscles. You can see a schematic representation of this phenomenon on the left, with the yellow brackets showing other reflectors that produce reverberation artifacts. We will now go over vertical lines. For the purpose of this talk, we will be referring to all lines that are vertical as vertical lines and not B-lines, as B-lines tend to be associated with a specific interstitial process, whereas a lot of other features can lead to what appears to be vertical lines. A traditional and common artifact is called the B-line, and it is the most common vertical line that we are aware of in ultrasound. This term regroups a large number of types of vertical lines generated from interactions of ultrasound waves with abnormal interstitium or pulmonary tissue. In essence, the concept at play is that ultrasound waves are generally reflected by structures in a specular pattern, as in an organized fashion. Part of them are directly reflected at a transducer and interpreted. Some surfaces produce a more diffuse pattern or scatter, as the tissue is too small to have an organized reflection towards its transducer and produce a well-defined image. Normal lung itself oscillates between no significant interaction and scatter, as the interstitium is too small to interact with the ultrasound waves meaningfully. At most, there is some diffuse reflection which leads to the grayish background to most normal lung. As the interstitium thickens, it creates pockets of fluid and air interacting that are now interacting from and changing the pattern from diffuse scatter to progressively more specular reflection. This clip shows a single vertical line. The characteristics of this vertical line that make it a B line are that it starts at the pleural line. It ablates the A lines, at least partially. It extends all the way to the bottom of the screen, assuming an appropriate depth as per the lung section studied, and moves with lung sliding. The thickness can be quite variable. This is a clip showing multiple vertical lines coexisting in a single lung intercostal space. The normal number of B lines is 2 or less per zone examined. It tends to be more in the dependent areas of the lung and represent usually early atelectasis. As the interstitium becomes progressively more thickened and the alveoli become opacified, the vertical lines can coalesce, showing larger width, as shown on the left clip. In extreme cases, or in cases related to non-interstitial pathologies, the whole lung can be in a whiteout, as seen on the right. Z lines are small vertical lines that are not B lines. They may represent small localized subpleural abnormalities or localized pleural thickening. These are short, do not extend far from the pleura, move with lung sliding, and do not ablate A lines as they don't go deep enough. They are not significant clinically. The next section will talk about constellation identification. Constellations represent loss of aeration of the lung. They are characterized by a more specular than diffuse reflection from constellated lung tissues. Usually they are tissue density, close in appearance to the liver. They are usually filled with hyperdense points that represent collapsed bronchivascular bundles. This feature usually allows to distinguish it to some degree from the liver. Constellations are often accompanied by pleural effusions, which tend to make them more apparent and facilitates their delineation. It is critical to properly determining the position of the diaphragm, particularly if assessing the right of the patient, as liver and ascites is sometimes confused with them. This is particularly present if the diaphragm is abnormally high, which is common in critical care patients. This is a good example of a consolidation with a pleural effusion close to the liver. The echogenicity of the liver is generally different enough from the lung that an experienced eye can determine this easily, but it is nonetheless critical to find the diaphragm. In this clip, at the top section of the clip, there is a small amount of ascites that separates the liver from the diaphragm. In this instance, you can see that the actual liver capsule is not as thick or bright as diaphragm. It might be a way or a clue to realize that you're not looking at the actual diaphragm if it is obscured by any other reason. Subpleural constellations can be found anywhere. They are also known as the Schredt sign. They represent a localized area of constellated lung surrounded by aerated lung. Generally, the pleura adjacent to it will not be sliding due to inflammation or thickening. The last section will talk about pleural effusions. Pleural effusions are a collection of fluid between the two pleural lining. As detailed in other videos, they are generally located in the posterior segments of the lung. They are generally circumscribed by the spine, the diaphragm, and collapsed lung. Most commonly, these are simple pleural effusions characterized by anechoic or dark fluid without any echogenic floaters, sediments, or strands. These are non-specific for exudate or transudates, and will be discussed in more detail in another video. The floating lung shape may vary depending on whether the effusion is the primary pathology or reactive to an underlying pulmonary pathology. Frequently, one may see a collapsed lung with a floating thin segment oscillating in the effusion. This is called the jellyfish sign and is typically, but not always, found in reactive pleural effusions. Pleural effusions can also be seen as complex, as determined by the presence of any type of echogenic material within the anechoic fluid. This can be sediment from a pneumothorax or empyema, or inflammatory strands extending from the lung to the parietal pleura. This suggests an exudative effusion, but is otherwise non-specific. This is the end of this video regarding pulmonary semiology. Feel free to contact us through our Twitter accounts with any questions or comments, or reach out to us on Sono Uni or Sono Vault.